Hello again, everyone. We are on to our second portion in our Introduction to Musculoskeletal Disorders video series, and this time we are going to be talking about fractures. And again, you can just be following right along. Your lecture outline has everything, as does your PowerPoint that's posted on Blackboard. So we're going to go over the types of fractures, we're going to go over a little bit about how they are treated, and the stages of repair of a fracture. So I'm pretty sure you know what a fracture is. It's a break in a bone, and but I want to highlight that a bone doesn't have to be broken in two to be considered broken. So broken and fracture mean the same thing. Any tiny little disruption in a bone is considered a fracture, and that's considered a break in the bone. So of course we most often see direct trauma as a cause of this, so whether that's a fall or a motor vehicle accident or just somebody turning the wrong way. Those are the most common causes. We do also see stress fractures, and those are generally due to lower levels of force but continuously applied to a bone, and we often see those, of course, in the lower extremity. And then finally we can see fractures in people that have pathological conditions that diminish the integrity of bone. So we'll be going through all of those. But first I just want to talk about some of the different types. And not all of the ones that are listed in your outline are pictured, and some of the ones that are pictured aren't listed. So you kind of can look at both lists. A capillary or a hairline fracture is similar to what that middle picture is, the fissure, where there's just a small little crack basically in the bone. On the left you have a green stick fracture, and this is very typical in children whose bones are very malleable and pliable yet. So it's named just like if you would take a stick from a tree that is green or still, relatively new off the branch, and you tried to crack it or break it in two, it often won't break in two completely. You'll get kind of splintering along the edges, but it won't actually break apart, and that's because, again, it has a lot of flexibility left to it. On the right, you see a comminuted fracture. And so say that word, comminuted. Very good, comminuted. And this is a typical fracture that we see, and it's when there's a lot of pieces. This is a complicated, serious fracture. It often requires some sort of surgical repair to get all the pieces back together. And when we start talking about treatment and repair, one of the basic principles of bone repair, fracture repair, is that the pieces have to be touching each other and they can't be moving around. So we'll be looking at those two principles when we look at treatment. So for that reason, fractures that are in a lot of pieces are complicated because all those pieces again have to get pulled back together to touch each other, and then they can't move around while they're healing. On the left, you see a transverse fracture. So this slide basically, it names fractures by their orientation to the bone or their shape. So oblique, of course, is at an angle, and a spiral fracture is caused by twisting, but again, you see that generally in long bones, and it creates kind of an oblique or elongated type of fracture pattern. Compound fracture means that the bone has part of the bone has poked through the skin. This is in contrast to what's called a simple fracture, where it could be any sort of fracture, but it just hasn't broken through the skin. And again, most fractures are not compound. Most are simple fractures. Even if they're very serious, they may not break through the skin. In cases where we see a lot of trauma, high trauma forces, this would more typically result in a compound fracture. So someone falling down a staircase, or falling out of a tree, or being in a motor vehicle accident, that's going to be more likely to result in a compound fracture, where the pieces of the bone have split and broken through the skin. We know skin is there to protect us and keep bacteria and things like foreign material out. So since the skin's been broken, and often again it's in a high trauma situation, there's a high incidence of foreign matter, dirt, other things getting into the area, so high risk of infection with someone who's had a compound fracture. There's two other types of fractures, either displaced or not displaced, and a lot of the pictures I've shown you have been displaced, and what that means is the bones are not in alignment anymore. So if you look over here on the right hand side, hopefully you know this is the ulna. The two pieces of the ulna are not in alignment, right? They don't line up nice and perfectly, so they would have to be reduced or realigned before we would stabilize it and want the healing to progress. We obviously don't want the person to heal in a crooked position. So here's another example, and this is a good illustration of also of why you want X-rays from at least 2 points of view. So here this is an AP view. Right here you can tell this is the tibia, the fibula, and this is the back of the calcaneus. And then here's a lateral view, the back of the calcaneus here, and again the same tibia. Can't really see the fibular fracture very well. You can see what is probably a lot of swelling around the fracture site. But again, it's displaced because you can see the pieces of the tibia are not lined up. Two pieces of the fibula are not lined up with one another. In contrast, here we see a fracture of the femur. This is an intertrochanteric fracture, so it goes between the lesser and the greater trochanter, and you can see this little crack here. So there's nothing that has created the femur to be out of alignment. Everything is in alignment. It looks fine. So this is a non-displaced fracture. So some of the complications we would see, I might have one more. Yep, one more. So this is a wrist, the radius fracture, and again there's a little fracture there and through here, and these are not displaced. They are lined up nicely. So some of the complications, of course, of fractures is it doesn't just damage the bone, but of course if there's a lot of trauma it's going to damage the soft tissue around the bone. If there's a lot of displacement, you could see ligaments or tendons being disrupted. Certainly see blood vessels torn, and those have to get, rebuilt, repaired. And as I mentioned before, you could also see infection, particularly with compound fractures. So let's go ahead and talk about how we would treat these fractures. So reduction means aligning the bony elements up. So reduction, reducing the fracture. And so in a displaced fracture, we need to line the bones back up before we would immobilize the bones. And so what you're seeing here is they're using a couple of methods. This isn't a Chinese torture device, though it kind of looks like it. They kind of use those little, I don't know if when you were kids you played with Chinese handcuffs. They're little spiral things that go around your fingers, and when you try to pull your fingers apart they tighten. That's kind of what happens here. They tighten here, and they're putting a little weight here so that they can create some traction and realign the bones in the forearm here. And then here on the bottom you see them manually doing the same thing. They're trying to line that up. Following that, then they would cast or splint or somehow immobilize the arm to make sure that the bony elements would stay in alignment. If they don't, then we'll talk about a surgical procedure. This is more of a close-up, so you can see here the fracture of the radius is displaced. It's not lined up, and so what they're trying to do is create some traction so that kind of pull this part of the radius back out where it belongs, get it lined up with the proximal part of the radius, and then to immobilize them. But as I said, if this doesn't work, then they may have to do a surgical procedure to realign things. So closed reduction means they don't cut open the skin stays closed. Open reduction means they have to open the person up surgically, and then once they open them up and line everything up, then they put in internal fixation. So O-R-I-F, we don't say ORIF, we say O-R-I-F, is open reduction, and then internal fixation. And you can see here that they are using any variety of sterile hardware store implements. So here's a nice drill and a screwdriver, and they're putting in screws here. They've put in, you know, some kind of metal meshwork here, wires, bolts, nuts, anything you can imagine, pins, nails, rods. Those are all types of things that are put into bone to hold it all together so that it can then heal up. Here's a rod going into a femur, so there's a mid-shaft femur fracture, and so what they're going to do is reduce it, in other words, line it back up, and then they're going to maintain that alignment with this rod. And so they basically cut a hole, drill a hole in the top of the femur, and they put this rod right into the intramedullary canal, and then they're going to put a pin across the bottom and across the top of the rod so it stays in place, doesn't slide around. And fractures, hip fractures are very common, unfortunately, in the elderly. So one last example. Again, they're putting a big long plate on the side here, and then with a set screw or a reducing screw here. So the fracture was through the neck of the femur here, and basically what they're doing is putting the screw in to pull the head of the femur against the neck of the femur so that it can heal. So if internal fixation doesn't work, they can always add it externally. And so the idea is that they would drill in above and below the fracture site. So they wouldn't try to go in internally and put in pins and screws and things like that internally. They do this externally. So again, above and below the fracture site, and line everything up. And so basically this is what it looks like. The person has this big external fixator on their leg in this case. I think this is just an adorable one. They have this tiny little external fixator on the thumb. Not so tiny little fixator, very big external fixator device on the tibia again. And the tibia has less blood supply than other bones, and so it has the highest incidence of what we call non-union. In other words, it doesn't heal after the fracture. Another area that you commonly see an external fixator is with the cervical spine. And so essentially what they're doing is they drill in, literally drill into the skull at 4 points, 2 in the front and 2 in the back, and they put on what's called a halo device. So they fixate the head, and then the person wears a vest, and so the bottom part around the thorax is fixated, and so then what that does is it immobilizes everything in the middle. So what's between the head and the thoracic spine? The cervical spine. So this is commonly done with people who have cervical spine fractures. Alright, that's it for our, oh wait, I've got another picture. So, see, he's happy. No, probably not very happy. But these are important. They're obviously, they keep the cervical spine completely immobile, and so it allows the bones to heal, and obviously they're trying to protect the integrity of the spinal cord. Alright, so let's go ahead and talk about the stages of healing. So you know blood has a very good blood supply, or bone has a very good blood supply in it. Do you remember the names of those canals? So we have canals that run up and down, and then we have canals that run side to side that carry blood vessels. So the Haversian system with the Volkmann's canals, and then the canaliculi. So there is a lot of blood supply. So a break in a bone is going to tear all those blood vessels, and so there is going to be a lot of bleeding. And so there is a, just like if you had a soft tissue injury and you had bleeding, there is a bruising or hematoma stage that lasts for a couple of days. And so areas around the fracture will swell up a lot, and obviously there's soft tissue as well as bony damage, but a lot of that swelling is coming from the bleeding from the bone. And then initially we have what's called provisional callus, which is just very soft start of bone tissue starting to kind of repair itself, what we call granulation tissue. Just kind of the granulation tissue is is collagen and blood vessels kind of growing together. So there's no stability to that yet, but it is the start of the repair process. And then what we see is bony callus. And within the 2 up to about 6 weeks, maybe 8 weeks, we see the development of bony callus. And after about 6 or 8 weeks, sometimes 4 weeks, it depends on the area of the fracture and the disruption of it. So a friend of mine just fractured a metacarpal and in her hand, and within 4 weeks that person was able to get out of a brace and start using the hand. Another colleague of mine, a friend of mine, fractured a metatarsal in her foot, and she had to wear a boot for 8 weeks, and that was the concern there was of course the higher forces and the weight bearing, as well as maybe not as good a blood supply in the foot. So it will vary, and you really need to look at the surgeon for when adequate bony callus has been laid down. They will just look on it in X-ray, and then when you look at it, you'll see like there's a big bump in the bone. Now I just want to let you know that over the course of the next several months, even up to a year, that bone then will remodel, and eventually these little bumps generally disappear and the bone just looks exactly like it did before the fracture. This happens a lot more easily in younger people than older people. So for example, my daughter had a very bad transverse fracture of her tibia when she was about 12, and 6 months later you couldn't even see where that fracture was. I mean, it was incredible. It was like it never existed. And if that happened in an older person, you would see some evidence of that. But I do want to dissuade you. There is an urban legend or some kind of myth that a bone repair is stronger than it was beforehand, and that's not really true. It's not true. The body, of course, isn't going to keep up any more cells than it needs to meet the demands of the tissue. So as long as the stresses on the bone kind of are equalized before and after the fracture, the body's going to just kind of go back to whatever bone cells it had there before for stability. So let's look at some X-ray pictures. On the left here you see the fibula fractured, and you can very clearly see this dark, very clear fracture line. And then 6 weeks later you see this callus. So this big kind of three-dimensional bubble bone that's grown around the area. And again, that's what's going to smooth out over the coming months. But this is what the physicians are looking for when they're taking X-rays when the person's going in for follow-up. You know, they generally go after about 2 weeks. They're looking for that provisional callus, and then after about 6 weeks they're looking for this more solid bony callus. Now this person obviously had ORAF, but they still need to make sure that there's bony healing going on. So here's a rod down in the tibia this time, and there's that interlocking screw at the bottom. And you see very clearly, even though this is 6 weeks, you see a little bit of here, you can see a little bit of gray, that light gray that shows some bony callus, but you still see the fracture lines very pronounced here. And then after 10 weeks, so at about 14 weeks, we're really starting to see a lot of healing going on. You see a lot of filling in of those fracture lines. At 20 weeks, they're considered to have enough callus to be healed, and you see a year later there's definitely still a little bit of bulging here, and so I would suspect if they took a X-ray in another year after that, there would be, again, it would look more smooth and more continuous, like with the line of the tibia. So again, this is already a year out and you're still seeing revision and remodeling occurring. So if you think about it, this really mirrors the same stages of repair that we talked about with soft tissue, right? You have the acute stage, then the subacute, and then the chronic stage, which is the remodeling stage. It's just that the time frames are longer.